we can say risk factors are there which the patient they should consider before they go
for surgery. So here in the laparoscopies, when we give a general anesthesia and when we put the patient to sleep, sometimes especially when there are prolonged surgeries, this kind of anesthesia and prolonged positioning of the patient, we will not be able to do in like patients with cardiac complications, like heart problems, patients with major lung issues. Because we put in laparoscopy, what we do, we insert gas into the tummy, we distend the tummy, and then we insert different instruments, we visualize the organs, and then we do the surgery. So when you insert a lot of gas into the tummy, you know that there is a diaphragm which separates.
So there are a lot of couples that also they are struggling in relates to the infertility.
In the infertility, where laparoscopy is useful is one is in some women they tend to have this polycystic ovarian syndrome. You must be hearing a lot about PCOS nowadays. So women who have PCOS, we usually say lifestyle changes first, that is weight reduction and maintaining healthy diet, exercise, all these things and all. And if they are not having regular cycles and there is no egg release.
Imagine a surgery where doctor does not require large cuts, yet they can see inside your body with stunning clarity. This procedure is so precise, the recovery feels faster than you could have expected. And if you talk about scars, it's almost invisible. So today's podcast is going to be really, really informative and interesting. At the same time, we are going to explore about the laparoscopic. And today joining with us are exceptional guest, Dr. Harika Bonam. She is an expert in laparoscopic and high-risk pregnancies. So be with us for this insightful conversation, which will definitely answer all your questions you might have. So let's get started. Dr. Harika,
Hi.
thank you so much, ma'am, for joining in today.
My pleasure. Yeah.
Thank you. So we'll start from the basic. Generally, we tell that laparoscopy is also called as a keyhole surgery. So, and I think it's a game changer in this surgical field. I just want you to explain what is laparoscopy so that our listeners who are not familiar with this, they can get to know more about it.
Right. So everybody must be knowing about the open surgeries and keyhole surgeries.
Yeah.
We say keyhole surgery. The other name for keyhole surgery is laparoscopic surgery. We also call it minimal access surgery. In minimal access surgery, we have laparoscopic surgeries and also robotic surgeries coming in this. It is not just the surgeries which are done on the tummy. We also do the surgeries from down below through the vagina by putting the scope inside the womb, from the opening of the womb, and we see inside and we do those things also. So all these things, they come in minimal access surgery. So now when we talk only about laparoscopic surgeries, when compared to in conventional surgeries, we give a cut. Say, example, you will have to remove a uterus, which is called hysterectomy. So when you do a uterus removal, we give a cut just above the pubic bone, about some 8 to 10 centimeters. Okay, and then you remove the uterus and you suture back all the layers again. So then the patient will roughly be having this much scar. Okay, a transverse or a vertical scar, depending upon how much is the size of the uterus, the surgeon will decide. Whereas in laparoscopy, we give 3 to 4 small openings. Each opening will be a size of 4 mm to 10 mm. So depending upon what kind of port we are placing to put the instruments. So usually we put one port or one hole which is 10 mm in size, that is 1 centimeter, and the other 2 or 3 small, that is 5 mm in size. So in this way we give only 3 or 4 cuts and we avoid the big cut. So that is actually the laparoscopic surgery. It can be 3 to 4 cuts, and there are also single port laparoscopies wherein we put one single big cut, one single, I mean the 10 mm cut or 1 centimeter cut, and then we put a special instrument and it has 3 holes on the top of it through which we can put 3-4 different instruments and we can finish the entire surgery in that just 1 centimeter cut. So all these things come under this laparoscopic surgeries.
Oh, that's really amazing, ma'am. If we say like earlier in the traditional way, how they used to have a large cut and the recovery time also takes. But there are, in every field, there will be some pros and cons.
Correct.
So is there any, in this field also, like we can say, any kind of risk factor will be there, or what are the main advantages? I can see that it can recover really fast as compared to the traditional.
Yes.
Apart from that, what all we can say risk factors are there which the patient they should consider before they go
for surgery? See, first I want to talk about the advantages. When we talk about the advantages, the first best advantage is cosmetic. Means you have just 3 or 4 small cuts which heal most of the time without a bare scar. A very small minimal scar will be there when compared to the conventional open surgery. The second important benefit is that the blood loss. Normally when we do open surgery, the blood loss will be roughly about 500 to 500 ml to 1 liter depending upon like what kind of surgery you are doing. Few surgeries even in open the blood loss is little less. But when you compare to the open conventional surgeries, in the laparoscopy, that is the keyhole method, the blood loss is more than half less. So it is usually only 200 or 300 ml unless it is a surgery wherein the patient has a very big uterus or a very big fibroid where there is a lot of bleeding happening. It is usually less when compared to the open surgeries. That is the second benefit. Third benefit in laparoscopic surgeries, because they are just small cuts, you'll have to just put one small stitch. You need not suture the entire layer by layer everything. So when you just put that one small stitch over there, the pain is less in the post-operative period when compared to the open surgeries. Similarly, because laparoscopic surgeries, the pain is less, the blood loss is less, the patient recovery is fast, the satisfaction rate is also fast. They can get back to their work also fast. So these are the main advantages in the laparoscopic surgery. Coming to the disadvantages, that is the cons. See, most of the times for laparoscopic surgery, yes, few surgeries we do under the anesthesia given in the back as well. But most of the times we require, especially when we need a long-term surgery duration period when you're expecting, we advise for a general anesthesia where we put the patient completely to sleep, not anesthesia in the back. When we see in the open surgeries, we give anesthesia usually in the back. So here in the laparoscopies, when we give a general anesthesia and when we put the patient to sleep, sometimes, especially when there are prolonged surgeries, this kind of anesthesia and prolonged positioning of the patient, we will not be able to do in certain high-risk patients, like patients with cardiac complications, like heart problems, patients with major lung issues. Because, we put in laparoscopy, what we do, we insert gas into the tummy, we distend the tummy, and then we insert different instruments, we visualize the organs, and then we do the surgery. So when you insert a lot of gas into the tummy, you know that there is a diaphragm which separates between the lungs and the abdominal cavity, between the thorax and the abdominal cavity. This gas will splint the diaphragm, and so the breathing will be a problem. So now your breathing will be under the control of the anesthesia doctor. We call them sleep doctors who put us to sleep. Now these anesthesia doctors will do the breathing from outside with the help of the equipment. So if your lungs or heart is compromised, they might not be able to actually support for long term, or they might not give fitness for laparoscopic surgery, and they rather might say, better we'll go for an open surgery. So that is one kind of situation where we usually don't advise laparoscopic surgery. Similarly, in patients, say for example, you must have heard about ectopic pregnancy, where pregnancy is not in right location, it is in the tubes instead of being in the uterus. And if some patient has pregnancy in wrong location in the tube, in early phases itself, sometimes it tends to break or burst. So if it bursts inside the abdomen, the patient will bleed a lot inside. If it is in the initial stages we have identified, we can do it in laparoscopy. But if the patient has bled a lot inside, like 2 or 3 liters, the patient has bled and the patient has come to you in shock, distending the abdomen with the gas will be problem because already there is a lot of blood. So then there are so many technical problems which we face. We might not be able to visualize the inside organscape in a proper manner. And the patient also, see, when the patient is in shock, you cannot wait for so much time to insert the gas, distend the abdomen, put the ports and all. The open surgeries in these situations are very quick. You just give a cut, go inside, evacuate, clean everything, and then remove that tube which is burst, and then you do the repair and come. Whereas in laparoscopy, the initial arrangements and all itself will take some time. So in quick situations where you have to do the surgery immediately, in those situations, sometimes laparoscopy might not be the right option. That is also one thing, and very rarely, like in less than like 1 or 2 in 1,000 probably we can say, at the time of insertion of ports. That means when you insert gas inside the tummy, and then when you insert the ports are through which we insert the instruments. Sometimes they may hit the major vessels inside your body. And if there is a major vessel which is stuck, and at the time of removal of the port, when you're putting a port, if there is an injury to these vessels, the patient tends to bleed a lot. And similarly, these ports which we put inside, they are sharp instruments.
Right.
Okay, these instruments when we are placing, because it is a blind method, but blind technique where you don't know where the port is actually going. With expertise, we do, because we do a lot of cases. Right. In the beginning phases, especially when the surgeons are too young or just have started doing laparoscopies, they might end up actually injuring the bowel or bladder. Bowel means the intestine, so bladder means the waterworks, that is the urine bag. Yeah. Or whatever. These things, they tend to happen, but the chances are really very less. With proper expertise, usually these risks are very less.
Okay. So I see like the technology also comes into the field, which really helps.
Right.
So what do you think, like how far it is helping the technology part here in this particular?
See, say for example, if you have to remove a fibroid from the uterus, a fibroid is nothing but a growth inside the uterus. Conventionally, what you do, you have a cut on the tummy, and then you identify the uterus, cut the fibroid, remove the fibroid, suture the uterus. That is how we do. In laparoscopy also, actually in few years before, they put the ports, they identify the uterus, remove the fibroid, but through the small holes, the fibroid cannot come out. So now in the last decade or last couple of years, with so much technology and all, there is something called morcellation. So morcellation is nothing but there will be an instrument which grinds the fibroid inside the abdomen, but we put a plastic sheet inside and we put the fibroid inside the plastic sheet. We grind it, we remove it in thin strips through the small ports. So that even we need not give a big cut actually in these situations to remove that fibroid. But we have to do it carefully. Whatever we are doing, if we are cutting some, specimen to remove it through the small holes, always it is better to cut it into small pieces inside a bag, because small pieces sometimes they tend to remain here and there. So it should not happen. So we should put it in the bag and then we should cut, and then we have to remove it through the small holes. So that is one thing. Next, there are so many advances even in endometriosis. There are so many things which we are actually doing now under laparoscopy. There are different new advances with which we are removing the superficial endometriotic peritoneum also. So these things, they actually have made a lot of changes even in the field of gynecology.
So even though those pieces get inside sometime, maybe some accidental thing might happen. So is there any problem?
See, usually with the fibroid, the problem is that non-cancerous growth which has developed in the womb. If small pieces are left over, what happens? Sometimes they tend to regrow from the place where they are there. So that's why what we do is, after putting it in the bag and removing it, we insert another instrument and then we lavage a lot of normal saline into that's a lot of fluid into the abdominal cavity, and we literally lavage the abdominal cavity so that everything comes into the pelvis, and again we keep sucking it, and we do it like for some time to see that there is nothing which is left over inside, and then only we come out. And when we are coming out, always we check the entire cavity to see if there are anything which is collecting anywhere and all, and we screen every place to see if there is anything in the nook and corner, and only then we come out.
So after surgery, generally patients come with any issues?
Most of the times after laparoscopic surgeries, the recovery is very good. See, on the same day also we discharge most of the patients when compared to the conventional surgeries. And the satisfaction with which they come to us, they usually refer the other patient saying, "Madam has done this to us, and we are now happy about it," and all. And the scars, we barely can appreciate those scars after a couple of years. Initial 6 months to almost 1 year, they tend to have some scar, but they eventually fade off, and then they will not be able to, most of the times will not be able to identify the scar unless somebody has a tendency of forming bad scars. So otherwise it is actually, the outcomes are usually good after laparoscopy.
So there are a lot of couples are also there struggling in relates to the infertility. So any piece of advice you would like to give them?
In the infertility, where laparoscopy is useful is, one is in some women, they tend to have this polycystic ovarian syndrome. You must be hearing a lot about PCOS nowadays. Yeah. So women who have PCOS, we usually say lifestyle changes first, that is weight reduction and maintaining healthy diet, exercise, all these things and all. And if they are not having regular cycles and there is no egg release, the second thing which we say when they are actually planning pregnancy is to give them a couple of medication to increase the chance of egg release. And then we give couple of medications, which we add metformin also, which is actually diabetic medication, which also sometimes help for the release of egg, along with the routine other egg release medications. And we sometimes give couple of injections. And when we feel the patient is not responding, especially when there is some other indication to this, sometimes we do something called laparoscopic ovarian drilling, especially in women with polycystic ovaries. When they have multiple cysts, there is a condition called hypertrichosis. So in these conditions, what we do is we do this laparoscopic surgery, and then we do small holes, which is called drilling in medical terminology, into the ovary. So what it does is it will reduce the hormonal imbalance, and it will increase the chance of the egg release in the next few months. Simultaneously, at the same time, we also put a camera inside the womb, which is called hysteroscopy, and we see if everything is fine or not. And then we push a dye from down below into the uterus, and from the tummy, we see if the dye is spilling normally or not from the tubes, to see if the tubes are open or not. So these things, they help them a lot in the initial few months after the surgery. Usually the benefits last for up to 6 months to 1 year is what they say. And also similarly, some women, they tend to have a septum kind of thing inside the uterus. It's like a small curtain inside the uterus, which is called septate uterus. These women, they tend, either they sometimes don't conceive, few they conceive nicely, few don't conceive, few have miscarriages, few have a mid-trimester pregnancy loss and all. These patients also, they benefit from doing a minimal access, that is hysteroscopic, that is a camera inside the womb, and we cut the septum. So in them also they help. Similarly, some patients with fibroids, they don't conceive. So these patients also, some of them, probably it might not always be because of fibroid, but after the fibroid surgery and after going for treatments, they usually conceive. And similarly, when we see endometriosis patients, there are so many endometriosis patients who have ovarian cysts and who have tubal blocks and all those things. So these patients also, post after surgery, removal of the endometriotic tissue, we usually check how much is the reserve of the egg, and we see the tubes are normal or not. And based on that, either they can try normally or they'll have to go for fertility treatment. But most of them, they usually conceive after the laparoscopic procedures. And nowadays, we are also seeing some patients who already had a tubectomy, that is a family planning surgery. They come and ask, now we have two girl children. Now we are thinking we want to have a boy, but we already had a tubectomy, but we don't want to go for IVF. We want to try naturally only. Okay. What should we do? So then also we can do a laparoscopic recanalization. That is the tight tubes. We can again, via laparoscopy, identify, cut the tight parts, and then we'll again resuture them. We anastomose them end to end. And the success of these surgeries, it can be something around 50% to 70 or 80%, depending upon how early the patient came back, how much is the length of the residual tube, and all those things. This is an alternative to IVF, that is the test tube baby, in women who had already had tubectomy and now they are considering to have a pregnancy again.
So generally, what is the recovery time period when we do the
anastomosis, when we tie it back? So usually after doing the tube, this is called tubal reversal surgery. This is reversal of the tubectomy. After 3 to 4 months, usually we do a test called HSG, that is a tube spill test, to see if the tubes have reopened or not. So that is the 3 months to 4 months is the period of time which we give for the tubes to reheal, and then we push a dye from down below and see if there is bilateral spill. Then there is a high chance that these patients, they can conceive naturally after that. But the benefit of surgery again will last for only couple of years, and the more that they delay later again the surgery, again the area where we have sutured, sometimes it can again scar. Okay. So immediately after 3 or 4 months, if the tubes are open, they can go ahead and plan pregnancy.
So generally, this HSG, which you mentioned, is very painful. Correct. So is there any alternate, like they can directly go for the lab instead of?
Actually, laparoscopy is more invasive when compared to HSG. Though HSG is painful, we usually give couple of medications and then we ask the patient to go ahead for HSG. Only if we are doing laparoscopy for some other indication, simultaneously in the laparoscopy, we can do the testing of the tube, which is called chromoperturbation. Because the patient is already under anesthesia, when you push the dye from down below, they'll not feel anything. Okay. So that is painless. But as such, the procedure laparoscopy, because we are putting holes on the tummy and all, it is little invasive, and anesthesia and all are little risky things when compared to simple HSG. Though it is little painful, it is better always when compared to the laparoscopy. Now, coming to alternative to HSG, there is also something which is called sonosalpingogram. Okay. So normally in HSG, we put an instrument inside the cervix and then we push the dye and then we see in the X-ray. In sonosalpingogram, inside the womb, instead of instrument, we put small catheter. Catheter is nothing but a plastic tube we insert, and then we push a fluid into the womb, and simultaneously we do a scan to see if the fluid is spilling both the sides or not into the pelvic cavity from the tubes. So this is little less painful when compared to HSG, but at the end of the day, it is also not completely painless, because either HSG or sonosalpingogram, we don't do it without anesthesia. We do it in OPD basis. So definitely little pain or discomfort is expected in these two procedures.
Yeah. So till now, it's clear that laparoscopy is really powerful tool and really versatile as well. So, like, who are thinking right now to do a laparoscopic surgery? What piece of advice you would like to give? I mean, or they should also still consider the traditional method, or the lab is the best choice for them?
First, if somebody is advised surgery, see, always surgery is just one option for any kind of problem. Let it be heavy bleeding during your periods, or let it be severe pain, or whatever is your pathology. See, most of the times we give multiple options. First option we give is usually a medical option for most of the gynec problems. Second option, there is also something called Mirena. Depending upon your problem, if this Mirena suits, it's a something similar to a copper T kind of plastic device. It is a plastic device which contain hormone. So this is a device which has been actually used in the last couple of decades, and it is actually doing wonders, and most of the women are responding to most of the gynec problems with this Mirena also. And so this is the second option. I would like to tell people to consider the non-surgical options as well. And in case if these two fail, or when the other non-surgical options are not working or failing, in those situations only you'll have to think about the surgery. And when you think about the surgery, always first the laparoscopic method, then the open method. Unless your doctor is saying that you are not fit for laparoscopic surgery and it is better for you to go for an open surgery, in those situations you can go for an open surgery. Otherwise, always laparoscopic or minimally invasive surgery, keyhole surgeries are better than open surgeries. Like any surgery, see, women who are obese, usually they tend to have a lot of risks post-operative or complications, especially when compared to the women who are thin. So anybody who has an option of postponing surgery or thinking of getting this done after 6 months or after 1 year, if it is not really a big problem, in those situations, if there is a time for you to plan before going for a surgery, please lose weight is something which I want to say, because the recovery in women who are normal weight is better after any surgery than women who are obese. And even the intraoperative complications, the anesthesia complications are also more in women who are obese when compared to the women who are actually in normal weight range.
Which is really
concerning. Yeah.
And there might be some misconception relates to these laparoscopic surgery. So generally, how do you encounter them?
The most important surgery which we more frequently do laparoscopy on a daily basis is laparoscopic tubectomy. That family planning surgery is something which is very easy, and it just takes 15 or 20 minutes for us. We put just 2 holes. We can do it also in 1 hole, which is called single puncture laparoscopy. So wherein we just put the holes around your belly button, and then we go inside, tie off your tubes with a rubber band. So this is laparoscopic tubal ligation. So this surgery is a so easy surgery, and the failure rates are very less, that is less than 4 in 1000. So now so many patients come to us saying that, especially the patients who come from villages and small towns, that doctor, we have heard that the current operation, there is high chance of failure. When they say current operation, they think it is laparoscopic surgery, and they say the failure rate is high when compared to the open surgery. In Telugu, they say kutlu operation. They say this open surgery is better, current surgery is not better. My mom told, my aunt told, my friend told. So this is something which is very difficult for us, despite we telling the evidence and telling them the failure rate of both are 4 in 1000 or less than that. And the recovery is pretty much better in laparoscopic surgery when compared to open surgery. Despite counseling also, some get convinced, some doesn't get convinced. They just look at that very small percent of failure rate which has happened somewhere to somebody, and they bring and say, no, we want an open surgery. So that is one thing which I usually encounter. Even for the other surgeries also, we see most of the times, some, especially when they come from village and all, they ask, we want open surgery, not the laparoscopic surgery, thinking that after laparoscopic surgery again the problem recurs, and better it's always we want an open surgery is what some women, they are still there like that, but we see it more only in the family planning or the tubal ligation surgery.
So who are like planning what Short of question they should ask to their doctors before they go
So
for the
before planning surgery, you have to know, because when they have to eat their food last, because we want 6 hours to 8 hours minimum nil by mouth. That is, we ask them not to eat anything for anesthesia purpose mainly. But when we are doing a prolonged surgery, especially in cases of endometriosis, or when we are suspecting adhesions in women who previously had cesarean sections, where they have multiple adhesions, especially with 2 or 3 cesarean sections, in those patients we usually ask for a bowel preparation before going ahead for a major surgery. This is mainly because at the time of laparoscopy or during the time of actually operating, by any chance if there is any injury to the intestine, the repair of the intestine which is well prepared is easy and better than compared to the repair of the intestine which is not prepared, because it causes a lot of contamination. So we usually ask 12 to 24 hours not to eat any solid foods, for minimum 12 hours not to eat solid foods, and before that to be little few hours on liquids and all. But this we usually discuss, and I mean a group of doctors, we discuss along with anesthetist also, and together we make a call when they can eat and when they cannot drink, all those things, and then we ask them to come and get admitted. So that is one thing you can ask. And the second thing is, please do ask about the complications, and please do remember what the doctor says clearly. Though the chances of complications are less, we don't want to scare you. Every time we say complications, it is because we want to make the patient aware of what has to be done and what has not to be done. Okay, and most of the times, after going inside the tummy, we identify a new pathology, and then what we have to do most of the times, we will be coming out and asking the attenders and all. Better than that, it is always better to be prepared beforehand itself. So ask your doctor, what if this is there, what if this is there and all, and then only it is better to go ahead and plan the procedure, is what I feel. And one more important thing, patients who have endometriosis, it is better to discuss with your doctor, because in endometriosis, where you have cysts in the ovary, which is nothing but the collection of your menstrual blood which has gone back, at the time of the removal of the cyst, even the healthy ovaries will be completely, sometimes even the healthy ovaries will be left only to some extent, that the reserve in the ovaries can come down. So these patients might not have any amount of reserve eggs or very less reserve eggs, and you have to discuss with your doctor, and then accordingly you'll have to plan fertility treatment later or before, depending upon what your doctor says. And also one more important thing is, some women, when they ask for hysterectomy, they ask for removal of the ovaries also. Okay. Because they say simultaneously take off the ovaries, because later what if something happens to the ovaries. But see, less than 45 years aged women, we don't remove the ovaries. Don't think that the ovaries are vestigial or not useful organs. Your ovaries will produce estrogen hormone, which is very important for your heart and the bone health. This estrogen is mainly important, and it is only because of this hormone we don't see heart attacks in the women in the age of 40. In women, most of the times the heart attacks happen only after the 50, because the estrogen will be protecting us. By any chance, at the time of removal of your uterus, if we remove the ovaries also, within couple of years your estrogen levels will fall, and you can end up in having heart problems or bone problems. Your skin also ages fast. All these things, they tend to happen. So if your doctor says no, let's keep the ovaries, please listen to her and conserve the ovaries, and do not go ahead and remove the ovaries. Ovaries, yes, in 5 to 10% chance there is a tendency to develop cyst at a later age, but this also can be dealt with the laparoscopy if really happens, but it is not a good advice to get your ovaries removed.
Okay, so you have done a lot of cases, ma'am. So any success story which you really remember? Like
few myomectomies, like few women who had the fibroids in the uterus, we have removed the fibroids through the laparoscopy, quite big fibroids, and later, I mean, initially they came from small towns and villages, few came from big cities also. They were told they didn't conceive for many years, and then they were told the chances are less, and then they gave up, and they were like, I just have a lot of pain, remove the fibroid, I'm not thinking about the kids, is what they say. And after removal of fibroid, within couple of months they come with pregnancy. And there are few women who have now kids, and they're very happy that because they have kids, and they're like, we never thought we are going to have a pregnancy itself, and now we have kids, is what they say. And similarly, if you have had tubectomy before, and this time they were like, we don't want to go for IVF and we want to try naturally again, and there are few success stories where we have tried tubal recanalization and they have come with pregnancy. So yeah.
Thank you so much, ma'am, for sharing all your expertise with us. We
Thank you so much.
More about this laparoscopic surgery. I hope all listener also who are thinking and planning for the same, they will get an idea. Now we'll have a short like rapid round, which is like fun
Sure.
round. We'll get to know more about you.
Right.
So are you ready, ma'am?
Yes.
Okay. So the first question I have, what's your favorite surgical instruments?
My favorite surgical instruments are again, yes, laparoscopic surgical instruments. Laparoscopy and hysteroscopic surgical instruments are my favorite.
Second question, a medical myth you wish like people would stop believing?
As I said right now, because I discussed about the lap tubectomy, I wanted them to know that no, lap tubectomy doesn't have higher failure rate when compared to the open tubectomy. That is one thing. One more thing, there are many people who believe that you should not eat pineapple in pregnancy, you should not eat papaya in pregnancy and all. See, actually, ripe ones are fine. Only raw papaya, they contain some enzymes or they contain some chemicals or hormones which can actually cause miscarriage. But ripe fruits, yes, all of them can be taken in pregnancy. So these two things I felt are myths which should not be actually listened to.
Great advice, ma'am. Thank you. So your go-to way, to relax after a long day in OR?
I actually love badminton and I love music, so I listen to songs a lot.
Okay.
So these two are my go-to relaxation.
Wonderful answer, ma'am. Thank you so much. Before we wrap up this, like any piece of advice you would like to give?
To all the women, if there is a problem, always attend the problem as early as possible. That is what I want to say, because see, for most of the gynec problems, we always give all the options. We give medical options, we give non-medical, other alternative options. As a last resort, we say surgery most of the times. When we give when we give these options, we see that most of the times women are like, no, we want directly to go ahead for surgery. Because what if the medical method doesn't respond? What if the Mirena doesn't respond? Then we have to go for surgery. No, straight away we want. No, don't do that. Always go. Take the primary options, because your problem sometimes will get solved there and then itself. Just in case if you need surgery, it should be the last resort. Say if you directly go ahead for a surgery, you have a surgery, your tendency of adhesion is there and you develop adhesions inside, and later you will require a second surgery. Now the second surgery, it will become more complex, and later if you require another surgery for another problem, so that becomes even more. So you avoiding a surgery means you avoiding a chance of you having a complication by any chance if you have a next surgery later. This is something which I want to say. So never let the problem become big. See, if you have menstrual bleeding which is heavy, go immediately to doctor, consult. If you have a fibroid and doctor says that this is so and so size of fibroid, go for Mirena. Don't think let's wait, let it become big, then we can go for surgery. We can think we'll come later, 6 months, 1 year, whatever the doctor is saying there and then itself, it will be a solution. Go ahead and get that solution. Do not delay it. At the same time, if there are non-surgical options, please opt for the non-surgical options.
Thank you, ma'am, wise word, and thank you so much for your time here, ma'am, and thanks for being here.
Pleasure is all mine. Thank you.
Thank you.